Local programming on KRWG made possible in part by viewers like you. Thank you.
Welcome to Fronteras, a Changing America. I'm Edmundo Resendez. Today we are going to discuss the Southwest Institute for Health Disparities Research at New Mexico State University. I am privileged to have as my guests Dr. Jill McDonald and Dr. Merranda Marin. Both have close knowledge of how the Institute works. Dr. McDonald and Dr. Marin, welcome to Fronteras, a Changing America. And one of the things I'd like to start out by saying is that in addition to being a professor at New Mexico State University, Dr. McDonald, you are the director of the Southwest Institute for Health Disparities Research, correct?
Correct.
Let's start out the conversation by discussing what is the Southwest Institute for Health Disparities Research. How did it get started and who all is involved?
Yes, first it's a very long name, Southwest Institute for Health Disparities Research.
The acronym seems longer.
The acronym is SWIHDR.
It's SWIHDR.
You say SWIHDR.
You say SWIHDR, okay.
Southwest Institute, SWIHDR. It really got started in 2007 when the New Mexico legislature committed funds to establish space for the Institute as part of the College of Health and Social Services. And that was finished. There was a wing on the building finished in 2012, and then I started with New Mexico State University in 2013, and directing that institute is now about 30% of my job. But we also have affiliated faculty across New Mexico State University, across the 6 colleges. We work with community partners, governmental at state and local level, as well as other academic partners. So there's quite a infrastructure is building, and we're quite involved broadly across the university and the community.
You know, it seems, again, as you mentioned, the different campuses that are involved, how many employees are involved in the Institute?
Well, there's 30% of myself, and we have a graduate assistant who is half-time, and that's really where we are. We're going to be talking, I think, here about some of the projects we're involved in, and some of those projects are funded. But those folks also have
so it's a very small staff.
It's a very small staff.
Okay, and this staff has to wear not just many hats, but many hats to accomplish the goals that have been set for the Institute.
Yeah, that's true. Okay. That's right.
Okay. Speaking of goals, what are some of the goals?
Okay, well, the big overarching goal is to reduce and ultimately eliminate some of the health disparities that we have in the U.S.-Mexico border region. And we have a slide for that. We're really working through research activities, through outreach activities in the community, training and capacity building activities, teaching. We're trying to work with all of that to come up with some novel solutions to some of these disparities that we really haven't been that successful with up until now. So across all of that, there's a theme, I would say, that's really necessary for us to be successful, and that is we need the academic expertise that we have from NMSU. What's the science? What's it telling us about some of these problems? We need the community expertise because we're very heterogeneous in the region, and just because something has worked somewhere else doesn't mean it's going to work for us, and we see that in the data. And then we need to learn to work together in really unusual and creative ways.
You mentioned border, and I think that, again, as you look at what your goals are, how do you define the border region?
Well, we use a definition that the U.S.-Mexico Border Health Commission uses. We have a slide also that illustrates the border that might be good for us to look at. It includes 44 counties along the northern side of the border, and that includes counties in New Mexico and Arizona and Texas and California, and 80 municipios along the southern side in Mexico, across the 6 states there. And actually, what the Commission did in 2000 when they established this geographic definition for the border is operationalize something that the two countries had already agreed on back in the 1980s through the La Paz Agreement. They were recognizing that there are some environmental issues that are unique to the region, there are some health issues that are unique to the region, and agreed to designate the region as a special place. And then in 2000 we established a commission, and the commission took that definition, which was 100 kilometers north and south of the border, and said, how are we going to measure that? Well, there's 44 counties that either intersect with that region or entirely contained in it, and there's 80 municipios. That's the region, and there are about 15 million people that live inside it, pretty equally divided between the U.S. and Mexico.
Okay, but 50 million people.
15 million.
15 million.
15.
Excuse me. And they're pretty evenly split.
Yes.
Pretty evenly split. You mentioned health disparities. What do you mean by that?
All right, well,
I'll
start.
jump in here. When we talk about, there's different organizations that will define disparity differently, just like Jill was talking about how the border region is sometimes defined differently according to different agencies. Same thing with the health disparity, it is sometimes defined differently. But in essence, we're looking at a discrepancy between resources or things that are conditions, diseases that are happening in one group more often than, say, in another group. And so for us, there's a wide array of what those disparities are. Sometimes when we talk about disparity, we talk about mental health disparity and how certain groups don't have access to as readily to mental health resources as other groups. Jill has, other examples of a disparity.
Yeah, I think there's a couple good ones, because there's different layers of disparities. There's different kinds. There's a racial ethnic disparity. Right. There's a geographic disparity. I think adolescent birth is a good one to use as an example. Adolescent birth is something that is associated with negative outcomes. The younger the women, the more negative health outcomes, social outcomes, not only for the mothers, but for the infants as well. And so the U.S. and Mexico have been trying to reduce adolescent birth rates, 15 to 19-year-olds, for decades, and we have been making good progress. But just because we're reducing adolescent birth rates doesn't mean we're getting rid of the disparity. And in this case, there's a disparity in birth rates. The U.S. Hispanic population has higher birth rates among adolescents than any other racial ethnic group in the United States. And then we look within the Hispanic population in the U.S., there's a geographic disparity. Women who live in the 44 U.S. border counties have higher adolescent birth rates than those who live in the other counties and in the U.S. overall. And if we could look at the next slide, I think it's a good illustration of rates in these three geographic groups. The line on the top, you're seeing there the decline in birth rates over the last decade for which we have compiled data for the border region. And you see that pretty much the red line on the top, which indicates numbers of births per 1,000 adolescents per year, is considerably higher, 10 to 15% higher than it is compared to the non-border counties, which is the yellow line on the bottom. So we've been reducing rates, we've been doing a good job, but we haven't eliminated the disparity. And if we look at the next slide, interestingly enough, it's the same on the Mexico side.
Is it?
Yes. It's even actually a little bit easier to see there. The line on the top are the 80 municipios along the U.S.-Mexico border over the last 10 years, and the line on the bottom is the non-border municipios. So same thing here. Mexico is making progress as well, but they haven't eliminated that disparity. And another example that might resonate with folks is diabetes, type 2 diabetes. It's a kind of a double whammy again. The U.S. Hispanic population has higher rates of type 2 diabetes. And then if we just look at the Hispanic population, we've got higher rates along the border. So those are the kind of things that we're talking about. There are disparities, there are differences in populations, like Merranda is saying, but there's something unfair about them. Right. There's some relationship between this disparity and other kinds of resources that may not be equally distributed.
What I have to look at is, what causes, what has been the cause of birth, pregnancy going down? on both sides of the border. It just seems very fascinating that that would be the case.
Well, both countries have had large family planning programs in place for quite a while, and I think folks who have analyzed these data in depth show that when we have a recession or when we have certain policies related to family planning in different states, let's say along the border, you do see rises and falls in adolescent birth rates. But really, I think the big question is, why are we overall successful, but not so successful in our Hispanic communities? We know what causes adolescent pregnancy. It's sexual activity and it's contraception behavior. But how do we influence those patterns? It's going to be different in different types of communities, and we need to tailor our efforts to those communities. We need to understand our communities well enough to be able to do that.
Is it a language barrier?
I think a language barrier is part of it. Few programs that have been developed to reduce adolescent pregnancy rates are actually targeting Hispanic youth. So language barrier is most certainly a part of the problem.
What is interdisciplinary research, and why is it needed to resolve health disparities?
I think that's an important part in trying to understand some of these things that Jill is talking about, because when we talk about interdisciplinary research, it really is a collaborative approach. Instead of looking at something from, let's say, my perspective, my background is psychology, therapy, what we're doing is we're coming together as a team and we're bringing all of our lenses and how we're looking at an issue, and we're kind of coming together to solve the issue. So it's a very systemic way of looking at some of these things that are going on in our community, and it allows us to be able to examine issues from, again, a wider perspective instead of a real narrow focus and a narrow scope that I would look at it if I was just doing it on my own. So we're coming together as a team to be able to do that.
And related to this, just this year, the Carnegie Foundation has classified NMSU as a community engagement university, which indicates we're not the only ones interested in interdisciplinary research and the only ones doing it. It's something that we do well here at NMSU, and something that we're being rewarded for and recognized for.
What kinds of health disparities is the Institute focused on?
We are focused in 4 broad areas. One is adolescent and child health, which we've talked a little about. One is adult obesity. A third is violence and trauma. And a fourth is healthy aging, is what we call it. And that's because we have academic interest and expertise in those areas, and because we have health disparities in the region within those areas. And we're working our way into those 4 broad areas, and we have various projects going on that we would classify in those 4 areas. I could tell you
what kind of examples can you give us of the work that you are currently engaged in?
Okay, I'll give you an example or so from each of those groups. Violence and trauma. That team is particularly interested in intimate partner violence. We have national data that indicate something like 25% of women experience intimate partner violence at some point during their lives, and the best data we have from the border region indicates it's probably a bit higher, 10 to 15% higher maybe here. So that's 35-40% of women in their lifetime, and that's what they're particularly interested in. And the thought is that we really need to be working across different sectors to understand better in our community why our rates are higher and why we can't reduce those rates. So, working with law enforcement and working with family shelters and trying to get at the reasons why women have difficulty leaving those situations and make it easier for women to leave. That's what the violence and trauma team is working on now.
And what are some other examples?
Okay, let's see. Well, healthy aging is a good example. That group is, instead of being focused on a particular health condition, they're looking at transportation, because transportation is so vital. It's vital to all of us, but particularly to older adults who generally have declining health, need more health care services, become isolated as they get older, and need ways to increase their social interaction. And yet we have a lot of older folks living in more rural communities and have declining abilities themselves to drive, to navigate, to travel in general. So their focus is, let's look at where all the healthcare facilities are that older folks can access, and then what's public transportation look like? Where do we have routes? How do people access it? And maybe there are some possibilities for change, filling in those gaps, and increasing transportation so that folks can take care of themselves more easily, can get more care, more screening, and that's important because if you can't take care of yourself well, you get more sick, you get more injuries, you're not screened for various kinds of chronic ailments that you might have.
With the other areas, the adult obesity, I was part of that team for a while. Mm-hmm. We were looking at working and connecting with primary care physicians and having a collaborative approach to how they talk to people about obesity and increasing their ability to have those conversations, to talk about how to look at stages of change. And if there's an issue of obesity, instead of just telling somebody you need to lose weight, looking at ways in which primary care physicians can utilize opportunities to ask people what are they already doing and how might they increase those changes in little increments. Those are some of the things that we were doing on that team.
Well, what are some of the effective solutions or interventions to reduce adult obesity?
One of the things that we know that is useful when working with somebody is to use a technique called motivational interviewing, and that's where you kind of gauge where is the person in terms of stage of change. Are they ready to make a full, complete change, complete in terms of completely changing their diet, their activity level, or are they maybe thinking about making some of those changes? And once you know where the person is in terms of stage of change, then you can target specific interventions for that level, with the ultimate idea that eventually you'll get the person to continue to move on to make some of those healthier lifestyle changes.
Let's talk about adolescent and child health. I think that's very important.
Yeah.
What kind of programs do you have that you're working with to work with this? Because again, as you look at the border region, 15 million people, that's a lot of, just with these 4 issues, we know there's more than 4 issues. So what are you doing with adolescent and child health?
Well, I think we have 2 main project areas that we're working on there. One is adolescent birth that we've just talked a little about. But we believe that that we really do need to work with the community in really unique ways. There are a lot of folks in Doña Ana County, for example, who've been working on adolescent birth rates for a long time. We'd like to sort of marry the science and what we know about behavioral change and what that takes, and societal change, and maybe policy implementation, and work with our community partners to come up with a new approach that's really modeled after priorities in Doña Ana County. How might we want to deal with trying to reduce adolescent birth rates in a different way, in a novel way, something that hasn't worked up until now. If we just look at the Hispanic adolescent birth rate in the border counties, for every 1,000 girls 15 to 19 years old, there are about 63 births per year. That's about 15% higher than what adolescent girls are experiencing if they don't live in a border county. And that's over double what the non-Hispanic white girls are experiencing in the border counties. It's about 29 births there for every 1,000 non-Hispanic white adolescents. So what is it? We're even living in the same place. Some of these things that you've already brought up, I mean, it's definitely related to the distribution of resources. It's related to poverty. It's related to education. It's related to language. It's related to what's the cultural sensitivity of some of these programs? Are we really dealing with some social norms that we're going to have to understand better?
What are some of the causes for teen pregnancy as to why it's so high in the border region?
Beyond contraception and sexual activity, I think it's these things. It's these well, we don't understand it. You know, really, most of the work that's been done has been done in the general population or in non-Hispanic adolescent groups. So it's hard to, you know, say for sure. I think it's something we need to understand a lot better. I think that's why we haven't made much progress on our Hispanic adolescent birth disparity. But there is enough evidence to show that that it is definitely related to socioeconomic status, to educational factors, to you know, the programs that have been most successful in other populations include parents, not just children, include male partners, not just females, include peers. You know, would those components be good in our population? And if so, how might, you know, we tailor those kinds of interventions to work better?
Well, you know, as I'm hearing you talk about this, I'm thinking of cycles. You know, what needs to be done to stop the cycle so that it doesn't continue happening in this region for these teen pregnancies to continue occurring?
Well, it is, yeah, I get, you mean a cycle, generational kind of
Yes,
cycle.
correct.
Yes, that's, well, I think that's why an intervention, that's probably a good reason why a successful intervention is probably going to have to include the whole family, not just the adolescent.
For that, and then I think we're kind of making movement in that direction when we talk about the child health and we talk about preventing childhood obesity. In fact, Jill and I are part of a grant-funded project in conjunction with Texas A&M University and with Arizona and Baylor to target childhood obesity along the U.S.-Mexico border. And I think that's one of the things that makes our project unique, is that we're not targeting just children, we're not targeting just the adults, we're looking at a family-based intervention and how to treat the issue. And I think that might be a model as we start to look at working with some of these other disparities. How can we get everybody involved? Again, it's a very systemic way of addressing the issue, I think.
Well, let's talk about New Mexico. You know, where is obesity in New Mexico at the moment?
Well, I can answer that. The state of New Mexico has been monitoring child obesity since really very well since 2010. I mean, actually taking measurements, and it's a school-based surveillance program. And just recently, just in the last year, we've seen that the overweight and obesity rates for kindergartners and third graders have come down. What that means exactly, I'm not sure, because they have fluctuated somewhat between 2010 and 2014, but it does look like we are making progress. That said, the rates, the prevalence of overweight and obesity among third graders in the New Mexico Hispanic population is 36%. That's about 50% higher than what we see in the non-Hispanic white kids.
You have a conference that's coming up in September.
Yes.
Why don't you talk to us about that?
All right. Okay. Great. All right. Well, this is our second annual conference for SWIHDR, and the first year we really laid a lot of the groundwork for what we're talking to you about now. We identified these topic areas where we had interest among faculty, and we kind of mobilized our faculty at NMSU. And
the conference last year was just really good, and it helped to, that's how the 4 areas, like you said, sort of grew out of that, because what the Institute did is it brought all of the researchers from across campus together so that we could say, oh, you're interested in this? Well, so am I, and this is how I'm doing it. And it kind of, you know, created some of these collaborations. And so it started with just the NMSU community, the campus community coming together. And I'm super excited about the next conference coming up in September, because that's where we're going to engage community partners too.
So it's on September 11th. Did you ask me what date? September 11th in the afternoon?
No, but I thought you might throw that in.
I am. Okay, it's for the afternoon, 1 to 5. But as Miranda's saying, we really want community in this year. Next year, we're going to be working binationally. We just have to go, you know, one step at a time. But the idea is, okay, so here we're working in these 4 areas. We have momentum. Let's really try to strengthen our partnerships in the community. We have kind of a cool thing happening at that conference where we have folks from the national level, CDC, from the state Department of Health, from the local legislature, and from some community organizations coming in to tell us how do they think a good academic community partnership should work. How does it get off the ground? What are the most important components? So we're really looking forward to seeing those different perspectives and try to sort that out, because everybody has their own perspective, as we all do. And we really, really very much hope that the community will be there. It's free.
Now, where is it? It's free.
At Domenici Hall.
Domenici Hall.
We have a website, I understand, will be posted here, and folks can go to that website to get more information. We're going to work out something for parking.
Well, yeah, you have to.
We will.
Now,
I hope the provost is listening.
As you look at the conference itself, you know, what's a goal? What's your number one goal, each of you, that you're hoping this conference will accomplish, being that it's its second time around?
My goal is, again, to just create that collaboration with the community. For me, I think that it's so important that as a researcher, we're working in conjunction with somebody else. So as a researcher, I may have book knowledge and I may have statistics, but I really want to work with my community partners, because they're in working with the populations day by day in the trenches, really seeing things. And sometimes there's a disconnect between academia and what's going on in the community. And I think we need to come together so that we can learn from each other, because that's the best way to solve the problem.
Okay, and in addition to what Miranda's saying, I want us to get more students involved, because I think we've got great undergraduate students. They live here. They're going to stay here. They're going to work in the health departments. They're going to be offering social services. They know the community. And really, I think the answer to a lot of these disparities is bringing the science and the community together in our own students.
That is Dr. Jill McDonald, Director of the Southwest Institute for Health Disparities Research, and Merranda Marin, Assistant Professor in Family and Child Science. Thank you for joining us on this episode of Fronteras, A Changing America.